So dietitians must rely on narrative reviews on facilitating education for older learners. While this knowledge provides important scientific information, there are virtually no reports on the actual preferences of older adults for their education materials. However, from the minimal body of evidence, it's seen that older adults find current education materials inadequate, superficial, contradictory, and difficult to understand. Despite these insights, the specific needs of older adults haven't been synthesized to date. So the aim of this study was to map and synthesize the existing literature on the preferred mode and delivery of patient education materials to older adults. A scoping review design was selected due to its ability to provide an overview of the available literature that's been conducted, considering there was quite a small body of literature. And 4 databases were searched, which were PubMed, Scopus, CINAHL, and Web of Science. Eligible articles included those which were published after 2010, with samples consisting of independently living older adults from high-income countries. Primary screening at title and abstract level was conducted by 1 reviewer, and this was followed by independent screening by 2 reviewers at the abstract and full text level. As outlined in the Prisma flow diagram on the screen, the search identified 3,245 publications for screening, and following the full screening process, 20 studies were eligible for inclusion. The preferences of older adults identified in the 20 studies examined were then categorized into the following groups: source, type, layout and design, and content. Regarding sources, it was found that older adults prefer to receive their health information from their GP and or from the internet. There was conflicting evidence regarding the use of the internet, with some older adults reporting that information accessed via the internet was really confusing and conflicting. However, several studies described the internet as a crucial means for older adults to independently manage and enhance their understanding of their health. Upon deeper exploration of older adults who preferred to source their health information from the internet, we found that the majority had ready access to the internet in their homes, so they were already quite capable with using the internet. And further evidence found that many older adults had a strong desire to use the internet as a supplementary source for additional health information following a GP appointment. Regarding types, the types of information materials explored included written, verbal, group, and audiovisual. And it was found that written materials, both printed and online, and audiovisual formats were most preferred by older adults, while the least preferred types were group classes, audio, and online courses. Further investigation into specific subtypes of materials found that handouts in the form of booklets, brochures, and fact sheets were most preferred, and a number of studies also described email and websites as a preferred source for some older adults. The least preferred material subtypes were apps, online lectures, podcasts, and text messages. Excuse me. 8 studies provided details on older adults' preferences for the layout and design of patient education materials. Specifically, headings were consistently reported as an effective method to enhance materials, especially if they were presented in bold, underlined, in larger text, and in colour. Additionally, informative headings rather than unclear statements were preferred. For example, steps to strong and healthy bones as a heading was preferred over don't take a chance on your bone health, which was much less specific. Older adults preferred to have text organised in short sentences and paragraphs, and found blank spaces and 1.5 or double spacing of the lines enhanced readability and clarity of the materials. Older adults stated a clear preference for sans serif fonts, which for Dana and Arial, over other serif fonts like Times New Roman, and ideally at a minimum size of 14. All studies reported older adults had a strong preference for the inclusion of visual aids in the materials, particularly in the form of photographs, which were more highly rated than line drawings or computer-generated graphics. One key recommendation regarding the use of visual aids in materials for older adults was that they should represent diversity of older adults, specifically regarding race, sex, age, and body size. Additionally, older adults supported a strong preferences for all visual aids to be labelled and accompanied by a written explanation which was linked to a material's key message. Regarding content preferences for materials, older adults reported a desire for key messages to be gain framed rather than loss framed, so written in a positive light of what you will gain if you do a specific recommendation rather than a consequence. Additionally, a clear statement of purpose at the start of the material was preferred to connect the reader with the priority information they should look out for. Furthermore, older adults reported that the accessibility of materials could be enhanced by ensuring that numbers are presented as both numerical figures and in text, ideally as frequency of probability rather than percentages, such as 1 in 1,000 rather than 0.001%, as that was more clear for people. Older adults described a preference for materials that were targeted and contained familiar content. For example, content recommending exercise should have included activities that are commonly undertaken by older adults, such as household chores, gardening, walking, golf, or tennis, rather than materials which focused on jogging or gym attendance, which may be less relevant to older adults. And specific information about healthy eating and lifestyle modifications for older adults, which they could implement, were also identified as highly desirable in several studies. Overall, these findings can be used to help practitioners and health educators design future resources that will more effectively meet the needs of older adults, and more detailed user testing with older adults was one of the recommended implications of this study. So if anyone has any questions, I'd love to answer them, but thank you.
Thank you very much for that wonderful presentation, Claudia. I'll first invite the judges to ask questions. And if anyone in the audience has a question, please relay that question through either the Q&A function or the chat, and then I will proceed to read it out after the judges are finished. But first, if the judges are happy to unmute and ask questions, please take it away.
Sure. I have one question. So what was the motivation to do this study for you?
Personally, after seeing lots of the materials used in practice, and they're very often black and white, just pages of text, and I saw a different study of mine was on reflections, and I saw patients that would just receive the same education material again and again, and it clearly wasn't working, it wasn't actionable, they weren't understanding it. So that really highlighted that the current materials aren't suitable. And then when we looked into background research, we just found that older adults are clearly not satisfied with the materials out there. They're not written at a readable level. They're not easy to understand. So we wanted to know what we could actually do and if there were any guidelines. And that's when we found there were no guidelines. So we sort of started looking into what the guidelines might be in the future to just have some background evidence.
Okay, thank you.
I have a question that which are these 4 databases which you search for, and why only these 4? Why not more?
We searched PubMed, Scopus, Web of Science, and Simmons. PubMed and Scopus and Web of Science mainly just because they were very, very large databases that brought in lots and lots of smaller databases together in the searches. And then Simmons it's actually a nursing database predominantly and health promotion, but we brought that in because it had a lot of references to health education and also a lot more demographic specific types of studies that we could search for. And because we had a very key target population, which was older adults defined as above the age of 65, we thought that would be a good resource. I don't really know why we didn't search more databases. I think it was just because these ones were comprehensive enough for what we were looking for.
Another one that, yes, you have shown the flow chart diagram of how you excluded number of publications, but you end up getting a very small number of publications. Could it be the case that with your method, you rule out more publications and there could be some interesting ones there.
I think we screened out a lot of studies that actually would have been really interesting to look at because we had a really strict inclusion and exclusion criteria. Initially in the background research, we were just getting thousands and thousands of results, but because we cut out all studies published prior to 2010, that excluded a lot of studies. And we did that because we wanted it to reflect the contemporary nature of, in the past 10 years, the way that we interact with the internet and with health promotion and with people searching for information has changed a lot. So we wanted it to be new and more relevant. But then also on top of that, making it only high income countries to make it relevant to Australia knocked out a lot of really interesting information and probably contributed to the fact that we found most of the participants in our studies weren't very diverse. And that was quite a big limitation of this study because of the studies we found which were really interesting on Indigenous Australians, we had to remove them because they were focused on that group as a demographic rather than being above the age of 65. So we excluded a lot of studies because they weren't specific to above 65 or they weren't specifically relevant to Australia. But I think a less strict inclusion criteria would have probably yielded probably very similar results, but more generalizable results.
Okay, thank you.
Fantastic. If the judges don't have any questions, there are a few questions in the Q&A from the audience. So I think, Claudia, you can actually check the Q&A as well. So the two questions are, firstly, what were the main types of studies included in the review? And secondly, how do your findings compare to guidelines, such as found in the PMAT, which is the Patient Education Material Assessment Tool? And are there specific things that differ for the older individual? So you can review those in the Q&A box as well.
So the first one, the main types of studies which were included were mainly interviews with patients or patients' caregivers, or some of the studies were studies on developing education materials where they used user testing and showed an over 65 population group a specific brochure and then another brochure, and they ranked which bits they liked, or some tested recall of when they changed fonts or when they changed sizes, but it was mainly done in a way that interacted with older adults, but very specifically on certain things. So we more combined, like they would look at type and then source. So we had lots of interviews as the types of studies. As far as how they compared to the PMAT guidelines, I actually did a second study in my thesis where I analysed all of the currently available type 2 diabetes education materials on Nemo and a few other resources, which are nutrition ones, but that was more specific to dietetics. And we found that the findings were quite correlated with the PMAT tool, because I used the PMAT tool and the CDC Clear Communication tool to evaluate those resources. As far as the PMAT guidelines, there weren't too many specific differences. It was more formatting differences. The PMAT doesn't specify font sizes or colours or more aesthetic preferences, but it did have other elements which were like less medical jargon, always labelling visual aids, which definitely correlated very strongly with the preferences of older adults. But interestingly, when we reviewed them, which are meant to be general for everyone, those studies actually did very poorly on the PMAT.
Fantastic. Thank you once again for your presentation and for your wonderful answers to all those questions. We'll move on now to our second presenter.
Thank you.
I would like to invite Kira Simmons to present her research. Thank you.
Thank you very much. I'm just going to share my screen. Can you see the poster?
No, we can see your desktop.
Okay, I'll try that again.
Yep, now we see the poster.
Yeah, perfect. Did you know that approximately 7.8 million worldwide premature deaths are related to vegetable intake below 800 grams per day? That's why I would like to talk to you today about vegetable intake in pregnancy. My name is Simmons, and I'm currently completing my Bachelor of Dietetics with embedded honors at the University of the Sunshine Coast. I would also like to begin my presentation by acknowledging the traditional owners of the land on which I reside, past, present, and future, which are the Gabi Gabi people. I conducted a scoping review on the literature to determine vegetable intake in pregnancy. This is important because diet quality in pregnancy is associated with both short and long-term benefits for both the mother and the child. We know that vegetables are low in energy and high in nutrients and make up an important component of a healthy diet. Although healthy eating is identified as a priority for pregnant women and also by pregnant women themselves, many remain below recommendations. The needs of populations differ by demographics, and so there's a real need to understand current vegetable consumption patterns of pregnant women in different demographic settings, especially those who are socioeconomically disadvantaged. There's a clear lack of synthesized data available on vegetable consumption patterns in pregnancy, intake over time, and also variation to vegetable intake according to maternal socioeconomic characteristics. Therefore, our aim was to, one, describe vegetable intake during pregnancy in both serves and gram and compare them to vegetable intake recommendations based on the country where the study was published. And secondly, to explore the relationship between vegetable intake and maternal sociodemographic characteristics. For the scoping review, we used the ACUR and O'Malley's framework and the preferred reporting items for systematic reviews and meta-analysis extension for scoping reviews, in short that's PRISMA, to adhere to standards of high quality research. We conducted an electronic database search of Medline, Web of Science, Global Health, and Scopus, and any study that was published up to July 2021 was included. We identified 1,916 articles. 962 of those remained after duplicates were removed. 55 remained after the titles and abstracts were screened, and those were then assessed as a full article. 47 met our eligibility criteria. All observational studies that assessed vegetable intake and pregnancy were written in English and conducted in an energy-replete context. That means that the diet provides adequate energy. Worldwide were eligible to be in our scoping review. There was large variation in terms of study design, range of participation numbers, and also where the studies were published. We had 35 cross-sectional studies, 8 cohort studies, 3 prospective observational studies, and 1 mixed method study included. Participation numbers ranged from 18 in a small cross-sectional study to 47,011 in a large 10-year cohort study. Out of the 47 studies that were included in our scoping review, only 13 had a representative sample of those women that are of lower socioeconomic status or are culturally diverse. Most of those were published in the US, so there's a real gap in the literature there. Studies were published in Australia and the United States predominantly, and then also in Spain, Sweden, Norway, Finland, Poland, the UK, and Japan. Publication dates ranged from 1998 to 2021, with over 1/3 having been published in the last 5 years, which shows that it's a current topic of interest. We had 4 key findings. The first being that while vegetable intake of pregnant women varied across population, this review found that vegetable intake fell below recommendations worldwide. 8 studies looked at vegetable intake in terms of gram and reported that the mean vegetable intake ranged from 75 grams to 295 grams. So that's a huge range based on what these studies reported. 16 studies reported vegetable intakes in terms of serves and said that mean serves varied from 1.26 to 3 serves per day. Greatest variation was seen in those studies that reported vegetable intake in terms of serves because national recommendations for vegetable intake in pregnancy vary significantly across different countries. They range from 2 to 5 serves, serve recommendations per day. Accordingly, those studies that reported what proportion of women actually met the recommendations also varied significantly because those recommendations vary. So the range went from 1.7% to 79.5% of women meeting the recommendations, which makes sense. If you strive for 2 serves of vegetables a day, it's easier to achieve that than if you're aiming for those 5 serves of vegetables. Our second main finding related to maternal and sociodemographic factors, and we found that studies that looked at older age, higher education, and higher income consistently found that women consumed more vegetables if they met these criteria, whereas if they were food insecure, they tended to eat less vegetables. Our third finding was that in regards to inconsistencies and inaccuracies that were occurring in reporting vegetable intake. And that's relating to the considerable variation in data collection tools that occurred. The studies that were included in the scoping review used a range of different data collection tools: dietary records, 24-hour recalls, screeners, and most predominantly food frequency questionnaires. All of these data collection tools collect dietary data in different ways, which obviously then leads to variation in reporting. But possibly the most important difference is that a lot of those data collection tools were not validated in the studies. So either some studies use data collection tools that were not validated at all, or they were validated to the country, but not the pregnant population, which is an issue if you consider some food frequency questionnaires look at the diet of the last 12 months, but then pregnancy is only 9 months long. So it really affects the validity. We also realized that there's no pregnancy-specific vegetable intake assessment tools currently available. And furthermore, there's actually no clear definition of what a vegetable actually is. So each study may have actually included different types of foods under that vegetable category. And lastly, no studies looked at vegetable intake alone. All of them also collected data on other foods as well. Our fourth finding is in regards to the other maternal and sociodemographic factors that were assessed in the scoping reviews, in the studies that were included in our scoping review. So studies looked at health-related behaviors in regards to vegetable intake, such as physical activity, smoking, TV watching, and takeaway foods. They looked at knowledge of dietary recommendations, pre-pregnancy BMI, country of birth, parity, so how many children a mother already has, planned pregnancy, stage of pregnancy, even stress and personality of the mother. But all of these findings were too sparse to actually generalize any findings. In conclusion, what we found was that vegetable intake in pregnancy needs to be addressed because recommendations are not being met worldwide, and we need to target this issue with appropriate public health strategies. In addition, our review suggests that a particular focus needs to be given to women of lower socioeconomic status because they're more vulnerable to low vegetable intake. I would like to conclude my presentation by thanking my supervisors, Dr. Judith Mayer, Dr. Nina Maloncelli, and Dr. Lauren Kearney for their continual support, their expertise, their amazing teaching abilities, and their co-authorship of this project. Thank you very much. I'm happy to answer any questions.
Thank you very much for another fantastic presentation. I'll now open the floor for judges to ask questions.
Yes, so you said the vegetable intake in pregnancy is low globally. So what would you suggest to increase that, to increase the intake?
It's a really, really good question. And currently there's actually, because what the research actually has identified are non-modifiable factors. Unfortunately, you know, income and age and also education are hard to change in individuals, unfortunately. And those factors that may be more easily addressed, such as social support and the stress of the mother, actually have not been studied sufficiently. We actually, in follow-on of this scoping review, my honors project was also conducting an intake study of a vegetable intake here on the Sunshine Coast in a regional setting. And the second part of that study was looking at what do women do that actually meet the recommendations, and can we develop an intervention based on what has already been shown to be effective in women that are meeting the recommendations. So hopefully soon we'll be actually addressing this gap in the literature.
I have another question, which is that how you mentioned about the 1.26 to 3 serves a day, how big the serve is, and also from your research, what do you think that how much either in energies or either in grams, how much you should be intaking either every day or throughout the pregnancy?
Okay, so a serve is either half a cup, that's a metric cup of cooked vegetables, or 1 cup of raw vegetables, like a salad kind of vegetable. So that would be one serve, but also it could be like 1 medium-sized tomato would be 1 serve as well. And in terms of, you mentioned what would I recommend? So the recommendations of Australia are the Australian Dietary Guidelines, and they recommend for pregnancy 5 serves of vegetables. So that's what is recommended. There was another question before that though. I can't remember what that one was, sorry.
Oh, it was like whatever the serve is, should you be following that how much energy should be intaking from vegetables, or how much, for example, in mass, or whatever energy or mass, what you should be consuming at the end?
Okay, so I think I actually am not sure what the grams would be, and the energy of vegetables actually quite low.
Yeah.
So we wouldn't really, and that's actually one of the reasons we should be consuming it, because then it helps kind of appropriate weight gain during pregnancy, because you're not over consuming energy. So really, in terms of intake, in Australia, we're really looking at the serve sizes, and consuming those 5 serves of vegetables will make sure that you are not over consuming on other foods, because it actually fills you up with the dietary fiber, but it also make sure you're getting all your micronutrients with that. So that's why that recommendation has been given.
Okay, thank you.
Thank you very much. Those are interesting questions.
Are there any other questions from judges or from audience? All right, if not, I'm happy to conclude that session. So thank you everyone for coming to today's session. Thanks to our audience, our wonderful presenters for really fascinating and interesting research, and of course to our judges for giving up their time. And so congratulations once again to all student presenters, and this recording will be made available after the conference, and we hope to see you at the remaining sessions of the conference. Thank you everyone.
Thank you very much. Bye.
Thank
Have
you.
a good day.
Very nice presentation.
Thank you.
Both of you. Thank you.
Thank you for judging.
Thank
Bye.
you.